Voy a ceder la palabra al profesor Kunitoshi Iseki de Okinawa, Japón, quien labora en el Centro Internacional de Apoyo a la Investigación Científica, es director de la Unidad de Diálisis del Hospital Universitario de Okinawa y miembro reciente del Comité Ejecutivo de la agrupación CADICO. Él hablará sobre estudios epidemiológicos del ácido úrico elevado, sobre la función renal y la longevidad. Seguido por el doctor Gianni Bellomo de Italia, quien por motivos serios de salud no ha podido viajar a México, sin embargo envió su material para que yo lo presente. La académica Magdalena Modero, jefa del Instituto Nacional de Cardiología de Nefrología, versará sobre el tratamiento de la hiperuricemia y la prevención de enfermedad renal crónica, para pasar al comentario oficial a cargo del doctor Juan Jesús Vázquez Ocampo y la sesión de preguntas, comentarios y conclusiones. Profesor Iseki.
Good evening, ladies and gentlemen. It's my great pleasure and privilege to be here and to show you the several epidemiological studies which I have been performed past 25 years. So I will show you first where is Okinawa. I think many of you may not be familiar with Okinawa, but as you can see here, it's very close to Taiwan and mainland China, Hong Kong, and Southeast Asia. And the population is about 1.4 million, which is about 1% of total Japanese. Okay? And one of the Okinawan people like to stress is Okinawa was the world's longest longevity area. This monument shows you, written in Japanese, but it was 1995, August 18. The governor of Okinawa declared the Okinawa is the longest longevity area. And the other 4 areas in world, which are called the blue zone. But I will show you the next slide. This is published in 2004 in August. The Time magazine, Okinawa was famous as a longest area. So that's caused by traditional lifestyle and food, as I show you here, and regular exercise, and social environmental, and the way of living. People are optimisms. But as this magazine shows you that Okinawa was famous, but that means why change, as we'll show you. This is the data from Japanese Society for Dialysis Therapy, the incident ESRD, end-stage renal disease patients by renal disease. It's in Japan that the computer registry system started at 1983. So as you can see here, the diabetes is the #1 cause of the renal disease. It became #1 since 1998, but it used to be a chronic glomerulonephritis. And you can see the mean age at start of dialysis in chronic glomerulonephritis in 2015 was about 68, and diabetes 67, and nephrosclerosis, maybe hypertensive renal disease, would be mean age at start of dialysis is 75 years old, which is very old. And this is the trend of mean age at start of dialysis. And both Japan and Okinawa, the mean age is gradually increasing. As in 2015 was 69, but Okinawa was 67, which is 2 years younger than national average. And this is the prevalent ESRD patients per million populations. So since 1983, the mean prevalence is increasing linearly both in Japan and Okinawa. But currently, 2,500 per million population. That means 1 per 400 Japanese are on dialysis. But as you can see here in Okinawa, it is more than 3,000, means 1 per 333 are on dialysis. They are living on dialysis. But I'd like to show, point out that in Okinawa, the prevalence is not, looks like hit the plateau. It's not similar, about 3,000. And this is the incidence of ESRD by gender. So the men and women. So the woman is about less than 200 per million population, but men is about 400. It means twice as high in women. So why we have so many in men compared to women, so that I'm thinking this is related to hormone or lifestyles or treatment compliance. Men is usually higher smokers and high intake of alcohol and less competent for treatment. So this is the summary or the epidemiological study which I have done for past 2 decades. So as you can see the left-hand side, OGHMA, this is the mass screening society. So they do start computer registry since 1983. So it's more than 106,000 in 1983. And 1993, it was 147,000 people in Okinawa participated at the general screening, including urine dipstick and blood chemistry. And on the left-hand side is Okinawa Dialysis Study Registry. We have registered all dialysis patients in Okinawa since 1971. So in past 30 years, the number was 5,246. So for this registry, we input the patients who survived at least 1 month of dialysis therapy, mostly hemodialysis. The firstly was 56 dialysis units and 78 physicians. So we combined 2 registries, so we can identify who entered dialysis registry among those who participated at the general screening. So this is the screening population by age at the screenings. So the average was about 14% of the total Okinawan people. But as you can see here, that the age 60 to 69, woman is about 1 per 4 participated of this screening. And this is the first paper we have published 2003. So there's a relationship with the dipstick proteinuria and development ESRD for the past 17 years, since 1983 to 2000. So we have only 1 point dipstick proteinuria, but as you can see here, that's a quite clear difference from the minus, plus, minus, 1 plus, 2 plus, and 3 plus, and more. So those who have 3 plus and more proteinuria have almost 1% per year developing ESRD. And one patient who had negative proteinuria developed renal failure in 7 years. So I have looked at the medical chart. So he was taking screening every autumn. So after 3 years, he developed proteinuria 3 and plus. And after 3 years, he developed end-stage renal disease. So even if you are negative proteinuria, you are negative on the day of screening, but nobody knows. You may have 3 plus next day, or 1 month, or 2 months, or later. So, but as you can see here, that at least 1 year, there was no difference in the cumulative incidence of ESRD. So we recommend for aged population, I mean more than 40 years of age, better to take dipstick proteinuria testing. And this is the incidence of ESRD by urine test for proteinuria and hematuria. We test both proteinuria and hematuria. And it is quite clear that proteinuria is more strong predictor of ESRD compared to hematuria. Although it is dose-dependent for hematuria, -2 to 3 plus over, but proteinuria 2 plus and over is quite clear that predicting power is strong. And this is incidence by blood pressure. But you can see, even at 1 point, blood pressure is a strong predictor of ESRD, both men and women. But as you can see here, the total cumulative incidence was 1.7%, which is 1/10 of dipstick proteinuria. So we know that the proteinuria is a very strong predictor of ESRD compared to blood pressure. And also we have looked at the creatinine clearance calculated by Cockcroft-Gold formula and proteinuria. So as you can see here, that red point is if you have proteinuria 1% over and the low creatinine clearance. If you look at the creatinine clearance 15, we accepted almost 100% for the dialysis. But if you have negative proteinuria, you have less incidence of ESRD. So then I will go to the story about uric acid. This is the distribution of serum uric acid. When you see, it's obvious that women is lower than men. The distribution is quite different. And this is the 7-year ESRD incidence by serum uric acid. So at the right-hand side, we'll see in men. So we show the number of participants, and among them ESRD. So because in women, the number was very small who have serum uric acid more than 7. We have looked at the highest serum uric acid was 6 and over. So as you can see here, that both men and women, higher serum uric acid is a predictor of ESRD, but in women it was significant. And this is also, we have looked at the another biomarkers of renal dysfunctions to see if the serum creatinine more than 1.4 in men and in 1.2 in women, based on the baseline level of serum uric acid. So both men and women had the increasing incidence of developing high serum creatinine, meaning chronic CKD. And also, in your left-hand side, right-hand side, you can see the other papers from Japan. So the serum uric acid versus risk of ESRD and death. So if you have a high uric acid, you have a higher incidence of ESRD and death. And this is our data to show you the prevalence of CKD by metabolic syndrome. Although that high serum uric acid is not a marker of the epidemiological syndrome, but we noticed that we need to modify the N-shape criteria to see if we have metabolic syndrome. So if you have full house metabolic syndrome, you have at least 2 times higher risk of CKD. Later, we have examined this one to see the CKD incidence are different by the presence of metabolic syndrome. So you can see the right-hand side, the 5-year incidence of CKD is about 2 times. And also, if you see the right-hand side, that the other part of Japan showed a similar result, almost twice as high in metabolic syndrome. So meanwhile, our data was included in the CKD Prognosis Consortium. So this is the flowchart to show you how CKD Prognosis Consortium was developed. So our data have a dipstick test and among general population. So people are not aware of the presence of CKD. So as I showed you the red characters, we have 2 cohorts from 1983 to 2000 and 93 to 2000. So almost total cohort would be 1.2 million. So we have other part of the world have general population with albumin creatinine ratio and high-risk population and CKD populations. This was published in 6 years ago. And this prognosis consortium is further developed and also used the new CKD classifications. And currently, the size of cohort developed more than 3 million. So we have lots of papers from this cohort. So the summary, as you can see here, the 1983, 1983, 1993, and 2003, almost 100,000 participants, and a similar prevalence of men and mean age about 50, and proteinuria CKD prevalence. But I want to show you that the body mass index is gradually increasing from 23 to 24, and clear obesity, body mass index 30 and over, was some 3.5 to 6.2%. Although it's much less than compared to United States, that obesity is increasing, and also the total cholesterol and fasting plasma glucose is increasing. That means we have a large number of metabolic syndrome people. But fortunately, the blood pressure is decreasing. So we have looked at the effect of uric acid. So this slide shows you the selection process of the study subjects. In 1993, we have 143,000 screenees. And 10 years later, people who screened again, 44,000. And we have looked at those who had serum creatinine and uric acid and other pertinent data, maybe 160,000. So we have study cohort 16,000. So this is meant to show you the effect of the change in serum uric acid level. Those who decrease 2 milligrams to increase 2 milligrams, the change in baseline eGFR and change in GFR. So this graph shows you that if you have high increase in serum uric acid level, you have a larger decrease in GFR in men. And similarly, this is in women. If you have increase in serum uric acid, you have decrease in glomerular filtration rate. So at this time, we had a formula to estimate GFR. So this is the effect of the eGFR change by baseline eGFR. So we have 4 groups who have more than 90, less than 90, less than 60, less than 46. Because if you have GFR more than 60, the estimation is not quite similar. Okay. So the group 1 is serum uric acid is normal, and group 4 is high and high. So we learned that the serum uric acid is something related to the CKD. So I will show you the other part of Japan. So we have 332,000 cohort. So as you can see here, that the lower the GFR and higher the proteinuria, you have high prevalence of cardiovascular disease. So if you are close to dialysis therapy, we have at least 1 per 4 had history of cardiovascular disease. And this is show you the metropolitan area, Tokyo, the general population screening. The urine pH is going down, and serum uric acid is gradually increasing, both men and women. But it's clearly different from men and women. So we have published several papers from Tokutei Kenshin, specific health check screenings. So even in the normal range in serum uric acid might be a risk factor of renal damage. So it seems that hyperuricemia is set 7 milligrams, but as in hypertension, the lower the better, but we don't know how low is enough. Also, we have a paper, the PROS1, that the health style, lifestyle factors are related to the non-restorative sleep. It means causes some problems. Recently, also from other part of Japan, serum uric acid levels is closely related to kidney dysfunction, less than 60, and albuminuria. So he showed that this is similar to us, that you have the high serum uric acid levels, you have larger decrease in GFR. So finally, I'd like to summarize the mechanism, why uric acid crystal-independent mechanism of kidney disease. So Dr. Hisatome from another part of Japan, he showed that here. So through the overexpression of renin causes hypertension, and also the vascular cells inflammation, and again, the renal angiotensin-aldosterone system activation causes vascular injury and renal arteriopathy, and leading goes to renal arteriolar damage, causes progression of CKD. So I think the hyperuricemia is a marker of lifestyle problems and should be managed either by drug or lifestyle modification. But we still need to have a prospective randomized control study. So thank you very much.
Muchas gracias, profesor Iseki.